So I want to introduce Dr. Ann Scheetz, and today we're continuing our overarching theme for the next several months, be part of the solution, come together to affect change by celebrating Women's History Month. Our speaker today, Dr. Scheetz, is a founding member of the decades-old Illinois Single Payer Coalition and a leader of the Illinois chapter of Physicians for a National Health Program. She is a woman who has worked consistently for her cause of a national healthcare system for everybody. Dr. Scheetz is an inspiration to all women and men, an example of what women can accomplish when dedicated to an issue and who works diligently toward their goal. I know she will be an inspiration to us all today. And to let you know how we're going to be arranging the program today, after Dr. Scheetz speaks, we're going to have breakout groups for a few minutes, and you can organize your thoughts and questions and ideas, and then we'll come back and Dr. Scheetz will have a question and answer period. So please welcome Dr. Scheetz.
Yay. Thank you so much, Frances. Hello to you, those of you whom I know already, and I'm glad to meet the others. Just to clarify, the single payer movement in Illinois is decades old. The Illinois Single Payer Coalition, that particular organization, was incorporated 11 years ago, and that's what I'm a founding member of. There were people organizing in Illinois around this issue before I got active myself. This has been going on for a long time. So I'll start out with a brief introduction to how I became an activist, and then talk about the healthcare system that we have, the healthcare system that we need and want, and how we're going to get from one to the other. And I hope I will not bore people with things that everybody knows, but I think we all, in this particular time, we all need to review where we are and where we want to go. I was a practicing physician for 30 years. I've been retired now for about 10 years. And during my practice, I always made home visits to people who couldn't get out to receive medical care. And in the course of that, I spent, of course, time in patients' homes, and I got to know not only my patients, but also their families. And so I saw the difficulties that people struggled with in order to get health care. And there came a time when I realized that I could not give my patients nor their families what they needed, and decided that I would turn over the care of my patients to other physicians, and that I wanted to work on the healthcare system, to changing the healthcare system. Unfortunately, I was able to do that. There were other physicians who could take care of my patients. And fortunately, also there were organizations in which I could get involved in working to change the system, including the Physicians for a National Health Program and the preceding organizations to the Illinois Single Payer Coalition. So that's how I got involved. So what kind of healthcare system was I trying to deal with, and that we still have now, that in some ways has gotten worse, and that we've seen in the pandemic how seriously flawed it is? We have a system that's extremely expensive, by far the most expensive in the world, about twice as expensive as the average of the organization of the states in the Organization for Economic Cooperation and Development, the OECD. And yet we have poor outcomes. Compared to other developed countries, we have lower life expectancy, higher morbidity, maternal morbidity and mortality, higher infant morbidity and mortality, among many other statistics that we could name. So for all of that money that we spend, we're not getting good results at all. We have multiple barriers to access, including for some people, lack of insurance. For other people, insurance, but such high deductibles and copays that they can't afford to access medical care. Care deserts, no pharmacies, no primary care, no obstetrics and gynecology, no mental health care. The vast majority of counties in Illinois have deficits in one or more, and sometimes all, of obstetrics and gynecology, primary care, mental health care, trauma care, and dental care. And we have very high financial burden. So there are millions of people who are impoverished by medical debt. And even then, maybe not able to access care, foregoing care rather than spend money that they don't have. And we have a very efficient system. So the first thing when you call to get an appointment, the first thing you're going to be asked is about your insurance. And somebody's going to spend time finding out whether your insurance covers the particular physician that you want to see. And then there's time and money spent on pre-approvals, on insurance billing, billing for $5.43, you know, for just multiple levels of bureaucracy that add nothing to healthcare and increase stress. And then we have a highly inequitable system. So there are people, the lack of health insurance is not evenly distributed. Black people and Latinx people are much more likely to be without health insurance than white people. Among the Asian American community, some groups, Koreans, for instance, are less likely to have insurance than some other groups. So, and then outcomes, as we know, the differences in life expectancy go up to 30 years just in Chicago from one zip code to another. Huge inequities. Maternal and infant mortality and morbidity far higher among Black people than among white people. So these are scandals to our healthcare system. And in contrast to that, so what kind of healthcare system do we need and want? Of course, a healthcare system that eliminates these serious faults. So we want a healthcare, and we have a name for the healthcare system that we want. We have several different names. We're never going to all agree on the same one, but they all mean the same thing. National Improved Medicare for All, also called Expanded and Improved Medicare for All, also called Single Payer Health Insurance. So what are the important characteristics of this? Every single person who lives in this country has health insurance for their whole life, from birth to death. You can't lose it, no matter what. You can't lose it for changing your job, for going on strike, for reaching age 26, for retiring, for getting divorced, for your parents getting divorced. Nothing can make you lose your health insurance. You have it for your whole life. And this insurance is automatic, and it doesn't change. You don't have to go from one coverage to another because you reach a certain age or because you change jobs. Everybody is under the same program. So that eliminates one of the inequities. Everybody has the same health insurance, regardless of your income, your job, your age, anything. And that insurance covers all medically necessary care under a single program. So you don't have to have separate insurance for vision and dental and mental health and pharmaceuticals and medical care. It's all covered under one program. That eliminates a huge amount of bureaucracy. And all necessary medical care, yes, we mean that. Mental health care, vision care, hearing aids, long-term care, wheelchairs, reproductive care, eye care, dental, insulin, everything is covered. Everything that's medically necessary is covered under the same system. And no out-of-pocket costs. That eliminates one of the huge factors in promoting poverty. No out-of-pocket costs. All the care that you get is free at the point of service. Of course, it's not free in the sense that we all pay for it somehow, but this is socialized payment through the federal government, that the whole program is covered. This is a huge gain in efficiency, in that you see a physician, or you go to your pharmacy, or you see your dentist, you show your medical card. There's a code in it that is used to bill your insurance, and it's paid within 2 weeks, as Medicare does now. Clean claim, paid in 2 weeks. And that's all that there is to the billing. No paper sent out to you, nobody trying to collect from you. And then, because everybody's in the same system, we have free choice of providers. So you can choose your dentist, your pharmacist, your primary care physician, your midwife, based on whatever criteria that you want to use. If that's geographic proximity, if that's somebody that's been recommended to you, whatever criteria you choose to use. Of course, that doesn't mean that that some of the providers may not run out of spaces. I mean, that can happen in any system, but you have a far greater likelihood of finding somebody you like when you don't have to worry about the network that your particular insurance company prescribes. So, and that's a huge gain in efficiency. For maximizing inefficiency, imagine that you're in an insurance plan and the physician who's just down the street from you has open slots, but is um, not in your insurance program. And therefore you might have to drive 40 miles to find a physician with whom you might or might not be able to get an appointment. I mean, talk about inefficient. We couldn't design a system to be more inefficient if we set out specifically to do that. So, and one of the things that we say about this system is everybody in, nobody out. That's what we mean by a system that includes everybody. So what would this mean in the pandemic? So no one would lose health insurance. As we know now, millions of people are losing their employer-sponsored health insurance. That's a huge weakness of the employer-sponsored service system. Of course, there are many others as well, and that all of the employers are change their insurance every year. You might have to change your physician, your pharmacy every year. If you lose your job and become poor, you have to go on Medicaid. That's an application process. All the Medicaid now is Medicaid managed. So we know the huge problems with employer-sponsored health insurance. And your employer changes insurance programs. You might have to change your physician, try to get your records from one to another, just huge problems. So no one would lose their health insurance. We wouldn't need any special legislation to make the COVID vaccine free because all services would be free at the point of care. And there wouldn't be this huge inequity between if you have COVID, if you get a COVID vaccine, it's free. And if you get another vaccine, you may have to pay for it. I mean, that makes no sense either. Every illness, every potential illness is a serious moment to someone. All of the care, nobody should be restricted from getting any kind of care because of the cost of it. So all the care would be free. And so, and then I want to emphasize that although this system would eliminate many of the problems that we have, that system that I'm proposing, advocating for, would eliminate many of the problems that we have in our healthcare system. We say that it's necessary, but not sufficient. It would not automatically take care of every serious problem in our healthcare system. So for instance, of great importance to the pandemic, it would not automatically rebuild the public health infrastructure that we have spent the past several decades destroying. I think it goes back perhaps to the 1980s or so, that we've lost hundreds of thousands, I think something like 200,000 public health jobs in the country. And we see now the disastrous consequences of that. And our whole public health system is very badly disorganized. So instead of taking testing and taking vaccines to the people, we're demanding that people go to the testing and the vaccines. Hugely inefficient. In the past, when we immunized, massive amounts of people, got virtually everybody in the country immunized against polio. This was not done when these vaccines were introduced. We did not do that by having people somehow get to a hospital or get to a sports stadium or someplace to get their vaccination. The vaccinations were taken to the schools. And that's how the early flu vaccines, they were taken to people. Now that's somewhat less common as people are getting more of their vaccines from their primary care physicians, especially among pediatricians, pediatrics patients, or from their pharmacies. But it's still the way to get massive amounts of people immunized in short order is to take the vaccine to the people. And the same thing, you have to do that with testing. If you want to maximize the efficiency of testing and contact tracing, you have to take it to the people. You have to go there. Saying this is the system that we have now is a product of our emphasis that we've come to have more and more in the public. I don't mean among all of us, but in the public realm, on individualism, and that it's individual responsibility to get vaccines and testing and so on. Well, we can see that doesn't work in a pandemic. Not if we want to maximize everybody's health, maximize protection for everybody. The most important thing is for everybody to get the care that they need, and then we're all protected. And if we depend on individuals taking responsibility and having the ability to get the care that they need, somehow finding appointments when most of the appointments are online, we can see that that means enormous numbers of people who are unprotected, and that therefore all of us are potentially unprotected. As long as the virus is circulating, we're going to have variants developing, and some of those are inevitably going to be variants that the vaccines that we have don't cover. We need new vaccines. This just doesn't work. We know that we're all connected. That's a practical point of view. So rebuilding our public health infrastructure and rethinking it, and thinking in terms of maximum protection for everybody. That's one of the things that will not automatically happen when we have a single payer healthcare system, but that is part that we need a single payer healthcare system in order to accomplish that. Obviously, we also can't have protect everybody if people can't get care or are afraid to go for care. A single payer healthcare system will make a dent in our inequities, but it won't automatically solve all of them. So it will mean everybody has insurance. It will mean that Mercy Hospital, for instance, gets paid for all of its patients just as much as Northwestern does, which is not the case right now. We know that Mercy Hospital is at risk for closing. A critical hospital, a safety net hospital for Black and Brown and poor communities, that's at risk for closing because so many of their patients are on Medicaid or uninsured. Roseland Hospital continuing to have constant serious problems. So that would be eliminated. Every hospital would get paid, but that won't automatically reverse all of the deficiencies that we've developed over decades. It won't automatically build pharmacies where there are no pharmacies, or install primary care physicians and OB-GYN services and mental health and dental services where they don't exist now. So that will be a problem we'll have to address. It won't automatically address the issue of healthcare workers who are very underpaid. So there are still healthcare workers in Chicago and Illinois who are making less than minimum wage. And this is concentrated among the people who provide the most intimate direct care to patients. So certified nursing assistants, transporters, the janitors, and there's never been a time when we recognized more the critical importance of all of these jobs, and yet these people get paid less than minimum wage, have few benefits. Of course, the benefit of health insurance would be taken care of under our system, but so that's another injustice that we have to address in order to have a well-functioning healthcare system. We need a healthcare system, and again, this won't be automatic, although it's something that we address in our proposals. We need long-term care that focuses on home and community-based services instead of institutions. Many of us are aware of the fact that we have a serious institutional bias in our long-term care. It's easier to get into a nursing home than it is to get home and community-based services that allow you to stay in the community. So that's another thing that we have to change. And the Illinois Single Payer Coalition's People with Disabilities Committee and our working group on long-term care are working on educating the single payer community about the critical importance of home and community-based services. And then the other thing that won't be automatically addressed and that we're very aware of is pharmaceutical reform. So under the system that we propose, the pharmaceutical industry would be not in the commanding position that they are now, in the sense that they would have to negotiate with a single buyer. So we all know what a monopoly is. A single seller, a monopsony is a single buyer. So under the system we propose, the only place for pharmaceutical companies to sell to would be the single buyer, the Medicare for All system. But there are many of us who believe that the pharmaceutical industry is so profoundly corrupt that that's not going to be enough. They might refuse to manufacture necessary drugs unless they could get the prices that they want. for instance. That's how thoroughly corrupt they are. They have a corrupt relationship with the medical profession. So that won't automatically be corrected by a single payer system. So many of us believe that we actually need to, people have proposed nationalizing the pharmaceutical system already. Much of the basic science development for new drugs is done in the public sector by National Institutes of Health. So the National Institutes of Health does the basic research. The pharmaceutical companies take that, make the drugs, do the tests, the research on the efficacy and safety, and control that to an extent that they shouldn't. Those tests should be done in the public sector so that we know that they're not being misinterpreted, which is a common problem. So that they're not being mispresented to people. And then the pharmaceutical companies, no matter how much of the research was done in the public sector, are entitled to keep all of the profits from those drugs. We, the people, are not entitled to get back the money that we spent on the development by having less expensive drugs. The courts have upheld that. So many of us think that the whole of the pharmaceutical development should be in the public sector. It's a falsehood that means that there won't be innovation. Of course there will. Scientists want to study and innovate, and we can have that and have it fairly presented to people. So those are the other issues that need, in addition to a single payer system, that we need to take care of. So how do we get there? So as we all know, the obstacles to getting there are the wealth and power of the medical industrial complex. The pharmaceutical companies, health insurance companies, investor-owned for-profit hospitals, dialysis centers, nursing homes, mental health facilities, the hedge funds and other financial players that buy up healthcare companies, extract all of the money and destroy them and leave people without care. So all of those people don't want what we want. They employ lobbyists. They have a large say in media coverage. They make huge campaign contributions to both parties. So these are the obstacles that we face, and they're huge. So why would we go up against such an enormous amount of power? And the answer is simple: because we don't have a choice. Because these organizations are in the process of destroying our healthcare system. Millions of us die unnecessarily every year because of the kind of healthcare system that we have. So how do we go up against such powerful interests? And again, all of us know we deploy people power instead of money power. So we have bills now in both the Senate and the House. The first Senate bill for the program that we're working for was introduced in 2017. There's been a House bill for a very long time. The current House bill has improved over the original ones, got much more detail. We have organizations of healthcare workers, physicians, pharmacists, nurses, medical students working for this. There are 3 dedicated national organizations working on single-payer healthcare: Healthcare Now, Physicians for a National Health Program, and the Labor Campaign for Single Payer. So I think the Labor Campaign for Single Payer now has maybe at least 20 major unions that are giving it financial support, not just in favor of it, but giving financial support. It's part of the single-payer healthcare, is part of the platform of the Green Party, socialist parties, Democratic Socialists for America, Progressive Democrats of America, and among people, there are Republicans and Libertarians who support this program. They support it for very practical reasons, because they need healthcare and they know this is the only thing that will work. There are 38 Illinois labor organizations that have endorsed our program in some way. Berwyn Township had a ballot referendum in 2018 that won for Medicare for all. I think it was 85% to 15%. The Cook County Board of Commissioners passed a resolution in support of Medicare for all in 2019. Illinois Single Payer Coalition has 11 member organizations, and we have a roster of 23 speakers who will go out and give talks about this. Most of the speakers are healthcare professionals or students, but not all. There are various kinds of people involved in it. So more about how we get there. And I want to mention a couple of the successes that we've had. So there's an organization of organizations that specifically works to oppose Medicare for all. It used to include the American Medical Association. And in 2019, the American Medical Association withdrew from that. And that was the result of a long campaign and a particular incident. So there have been people working within the American Medical Association for many, many years to change its position, its opposition to Medicare for all. And this is especially young physicians and medical students who have been working on this. And the younger physicians are passionate about the need to change. They don't like the healthcare system that we have as a future for them to work in. So that has been going on. And then in 2019, when the American Medical Association met in Chicago, their House of Delegates, the medical students within the AMA got together with Jane Addams Senior Caucus, a senior organization, and many other organizations, Physicians for a National Health Program, Illinois Single Payer, Public Citizen, a lot of other organizations from Chicago and around the country, and staged a demonstration. And when we have during the breakout groups, I'll put in the chat a link to a video about that demonstration. So young people and old people together, the young people, the students, were the people who figured out how to do it. They had been to these conventions before and they figured out how to get people in. And seniors and people with disabilities were able to get into the convention and disrupt it and hold a die-in. It was brilliant. Meanwhile, a great many more of us gathered outside and had a demonstration first at the Blue Cross Blue Shield building and then at the AMA's hotel. And yeah, it was marvelous. And it was after that. So it was decades of internal organizing and then a particular effective demonstration that was the turning point that brought the American Medical Association to withdraw from that organization. And the vote that year, there have been a number of votes on whether to support Medicare for all. The vote that year was still not in support of it, but it was only 54% against it, and that was down from a much higher level of support in the past. So that's a victory that we've had. Another victory that we've had, the first Senate single payer bill by Senator Bernie Sanders in 2017 excluded long-term care from Medicare for all, specifically excluded it. The Illinois Single Payer Coalition's People with Disabilities Committee and our working group on long-term care set out to work to change that. And we developed a paper. We went into great detail in analyzing the proposal Physicians for a National Health Program had made on long-term care, analyzed it from the point of view of people who actually use long-term care services, and came up with a detailed critique and proposal. We circulated that to hundreds of groups and individuals in the disability rights community and in the single payer community. And in 2019, the new Sanders bill that year included home and community-based services. It still doesn't include it still doesn't include nursing home institutional services. And even though we don't want those services for most people, they have to be included. So we're continuing to work on that. We thought that was a huge victory that he included home and community-based services. And the House bill that year specifically included all long-term care services. So those are a couple of ways that we've had some victories. Other things that we're doing. During the breakout sessions, I'll put in the chat our Patients Over Profits petition. So it's a petition to Senators Durbin and Duckworth asking them to stop taking money from the health sector, from the for-profit health sector. And I hope all of you will decide to sign it. The working group on long-term care continues to work, as I said. We're supporting the struggles to keep Mercy Hospital open. We supported the nursing home workers that were on strike a few months ago. So these are ways that we build alliances. We go out in support of any labor group that is fighting for health benefits. educating them on the need for health benefits for everyone at the same time that we support their struggles. So, and building these alliances, I think, is critical, including building alliances, especially with groups that are led by Black people, by people with disabilities, by the people who are most disenfranchised under the current system that we have. Where those groups take leadership, we feel that we need to support them because they are the ones, they who suffer the most under this system have the greatest power to transform it into what we really need. So again, we say everybody in, nobody out. And I will stop at that, and I will be happy to take questions and hear comments after we come back after the breakout sessions. Thank you.
Thank you, Dr. Scheetz. Okay,
I think we're all back.
all back. Okay, Anne Marie, you were in group 1, so why don't you start us out?
Okay, what we were talking about in our group was some of the things that we were concerned about. We were talking about how right now there's a lot of misinformation, making socialism sound like inferior type of medical care. And we're wondering, how do you stop the misinformation? And 2, what would be the progress towards this single payer? It probably wouldn't happen overnight. And how would we have more than one type of insurance during the progress towards a single payer? As someone brought up, we know right now Medicaid is not treated the same way as private insurance or as like employer insurance or Medicare. And so the other thing we're asking about is the people are really concerned that there might be a lessening in the quality of care. People talked about friends who are in other countries and how they say that the doctors don't like the national health care because they don't make enough money. And so how do we handle that? My question, this was my own personal question, was how do we make sure that private, that doctors and nurses and everybody in the healthcare is treated like professionals and given a professional salary? Because we know that as private schools, we don't treat our teachers as professionals. We treat them more like high-class babysitters. So we want to be sure we keep the quality of our healthcare at a high level.
One thing I think among young people now, there's evidence that they're much less frightened of the term socialism than people used to be. In fact, you can see people talking about how terrible capitalism is for so many different reasons, and that we need to have more socialism in many respects. I think that just continuing to talk to people about the failings of our current corporate healthcare system, how corporations, from pharmaceutical companies to health insurance companies to for-profit, investor-owned for-profit hospitals, which have lower quality care and higher costs. I'm talking about all of the problems that are introduced by the system that we have now, which is so corporate. What is progress toward getting where we need to be? So the single payer movement is not united around just one action at this point. And I think that we shouldn't be. I think there are many different avenues that are still fruitful for pursuing. So there are people working on moving Democratic representatives who have not yet signed on as supporters of the House single payer bill to do that. That's been an ongoing campaign, and we have made progress in persuading some to do that. So if you live in a district where that's a possibility, that can be worth working on, as long as other people want to do it with you. So there has been work, for instance, in the 5th district, Quigley, and the 8th congressional district, Krishnamurti in Illinois. Also working on the senators, not that that's going to be easy, but we feel that they should not be just let off the hook. So the Patients Over Profits campaign, for which I put a link in the chat, is directed at Durbin and Duckworth to get them to stop taking money from the for-profit healthcare sector, that's part of a national campaign that's going on here and there, where people have decided that's something that they want to work on to persuade people in Congress to stop taking money from people they shouldn't be taking money from. So that's another place where work is going on. As far as sections, the AMA, the work on the AMA is still not done. There's still young doctors and medical students working inside the AMA to get them to actually further reverse their position and actually support Medicare for all. There's also work going on in other medical societies. Every specialty has a society, so there's work going on in some of those societies to get them to support Medicare for all where they don't already do so, and some have done so. Another possible target that people are discussing is the American Hospital Association. So that's probably harder than the AMA to address, because the people who actually have power within the AHA are people in administrative positions, and they tend to be less, although there are some who support single payer, they're not as intimately familiar with how bad the current system is as physicians are, who have to deal with all the defects of our system. How about the transition period? So that this is not an issue on which we've reached consensus. Most of us believe that we should have an abrupt transition, as we did with introducing Medicare back in 1965, that one day Medicare was in effect and every person over the age of 65 was eligible for it. And within a year, more than 95% of all the people in the country who were eligible were signed up, and using the insurance. And this was in the days before computers. So we could do it from one day to the next. So after the passage of the law, 1 year period to get things set up, and then everybody's in. The House bill that was introduced in 2019, which has not been reintroduced yet, gave a 2-year transition period. So the oldest people and the youngest people would get insurance in the first year, and the people in the middle would get insurance in the second year. Many of us think that's a dreadful plan, that introduces, when we say everybody in, nobody out, we mean that introduces conflict between some people getting it and other people not. The people who would wait an extra year, the vast majority of people in the reproductive age group where we have terrible inequities and just shameful statistics would have to wait an extra year. If your birthday was the day after, from one day to the next would make a difference in whether you waited 1 year or 2 years. We just think that that's a dreadful situation to be in. There's no question that we can do it if we choose to do it. We've done much harder things. And the system we have now, where people are changing insurance every single year, I mean, what could be more disastrous than that? So we believe in an immediate transition for everybody.
And one other question I forgot was, how is it going to be paid for? And will all other insurances be done away with, like Medicaid, Medicare, and employment insurance?
Right, okay.
Those were the other
Yes, there would be only one insurance. Now, people could buy insurance for things that are, if you wanted to buy insurance to have, a fancy hospital room or something, you could do that if somebody wanted to offer insurance for that. But for all necessary medical care, it would be covered under one insurance, and other insurance, it would be prohibited to sell anything that's covered by the national program, to sell it as a private insurance, because that introduces tiers in which some people have more than others. We want everybody to have the same care, the same coverage. Decrease in quality. We can see from the statistics that we have compared to the amount of money that we spend, there's no developed country that has worse care than we do. So our quality can only increase if we have national improved Medicare for all. The quality will improve because people will have access to the care that their doctors recommend. It will improve because doctors will not be spending thousands of hours a year on administrative tasks, but they'll be spending it on actually caring for their patients. It'll be a huge stress reducer for both clinicians and patients, and not having to worry about insurance issues. when people need cancer care, you'll be able to refer them to the place that has the best care that they need, not to the one that's within their network.
Ann, I hear what you're saying, but that's pie in the sky. Black people are already, we don't have the resources in our communities. And how is Medicare for All going to address that?
So there, I think perhaps you weren't here during my talk. So there are two things. So yes, Medicare for All is necessary but not sufficient for addressing inequities, racial inequities in particular. So the part that it addresses is that every person, regardless of their color, their neighborhood, whatever, their employment, will have the same health insurance as everybody else. It will, a single payer program will not automatically take care of the fact that right now healthcare facilities and access to care are so unevenly distributed. So it will be necessary to address that, to particularly invest in facilities and personnel in the areas that now don't have them. So the areas that don't have trauma care, primary care, dental care, mental health care, pharmacies, that those need to be built. So that's part of the necessary but not sufficient task that we have. We also know that there is racial bias embedded in the healthcare system in other ways. For instance, that clinicians are less likely to treat pain seriously when it's a Black person who's complaining of pain than a white person. And those issues also will not automatically be addressed by a single payer system, but they cannot be addressed outside of a single payer system because the resources are so inequitably distributed now and are continuing to be. Under our system, Mercy Hospital would not have to close because it wasn't getting paid because all of its patients, so many of its patients are on Medicaid or uninsured. Jackson Park's obstetrical care would not have had to be closed because of lack of money, because they would have been reimbursed for all of their patients. So let me see what else. Physician satisfaction. I mean, their physician satisfaction is dreadful in our country. It's worse than in other countries because physicians spend so much time dealing with insurance issues, trying to get pre-approval for things that they're turned down on. Somebody documented or projected that psychiatrists spend a total in the United States, spend 1 million hours per year just on the task of sitting on the phone trying to get approval for patients in mental health crisis to be admitted to an inpatient mental health facility. That's an example of how cruel our system is. Yes, the position of healthcare professionals. I think that, again, a single payer healthcare system is necessary but not sufficient for addressing that. As you said, Anne-Marie, we treat so many of our professionals now like nothing. I mean, I think that's part of the system that we have that's run by insurance companies. For them, physicians and nurses are just an impediment because they're always asking for money to take care of somebody. And we want to get insurance companies completely out of the picture. They won't be involved at all. So physicians and nurses and their patients decide what care is needed, and then you get it. It's paid for. How to pay for the system? Well, I mean, there are various ways we could do it. We believe it should all be financed at the federal level. That's the only way to address the huge inequities among the states. For instance, on the whole, on average, the southern states have much worse health outcomes and lower quality of care compared to wealthy, for instance, Northeast states. We can only address that at the federal level. But the system that we have now, when we consider the fact that we're spending at least 15% of all of our spending is on unnecessary administrative projects. And when we consider that we spend more money than any other country in the world, it's absurd to say that we can't afford a single payer system where we get rid of all this huge administrative waste and devote the money to actually caring for people. What we're going to do is not have people having to take money out of their own pockets, but have it all financed by the government. So government spending will go up. It's supposed to go up. Total healthcare spending can go down, and we can take care of everybody if we get rid of the administrative waste. So I hope I adequately covered those. I'll be happy to come back to those after we hear from the other groups, whatever questions they have.
Thank you, Group 1. Group 2 is the group that I was in, and I think you may have answered Patrick Curtin's question. Now that AMA has stopped their resistance to single payer, who's next likely resistance? And I think you may have gone over there with insurance companies, et cetera. Did you have
So the
anything?
AMA hasn't stopped. They took one step, which was, so that's the thing. We have to take this step by step. There's no other way to do it. So they dropped out of the particular organization that they were in. They've still not voted to support Medicare for All, and there are people within the AMA still working on that, and we may end up with another action against them in the future. Of course, in-person actions are more challenging nowadays. Go on, Francis, sorry.
Anything else from group number 2? If not, we'll go on to group number 3. Okay, I have a question
From
aid, which may reduce state taxes.
Okay, yes, so the part about state taxes, I mean, that's not for me to say. That's something that we all have to work on, what state taxes we want and what we want to do with them, but they would not have to be spent on Medicaid. Yes, we want all financing to be at the federal level. Obviously, states have huge issues that they have to address, and healthcare should not be one of them. So, and Medicaid is eliminated because everybody has the new improved and expanded Medicare.
Just in general, do you think that, well, you kind of addressed it, and people want to know how you're going to pay for it. How do you answer that question?
Well, so my answer to it, and there's not consensus on how it should be paid for, but my answer is that we cannot afford to not have single payer because we are wasting so much money now on administrative projects that contribute nothing to people's health, and in fact, that damage people's health, because so much of our administration is devoted to denying care. Okay,
So my question that's in chat, can I ask it or no?
Yes, please
Yes.
do.
Okay, so you spoke about the insurance companies.
Mhm.
You spoke about how you're putting together coalitions. Are the insurance companies being partnered and brought into the discussion? The concern that came up when our group was talking is, you get rid of the insurance company, a lot of people are going to lose their jobs. And that's a financial impact that needs to be taken into account and accounted for.
So what we've proposed, and this has been from the time of a single payer bill was first introduced in the Congress, which I forget when that was, it was a long time ago, was that there should be funds for transitioning people who lose their jobs from insurance companies, severance pay, and the opportunity to trade in other fields. But many of us believe that it would actually make more sense to, well, we know how many people have lost their jobs. Immense numbers of people have lost their jobs. That it makes much more sense to just pay people who lose their jobs. That would be better, to pay them to stay at home. That would be much better than paying them to deny other people access to health care. And I don't think that this is, I use the term pie in the sky, Deborah, and I don't think this is pie in the sky at this point when so many people have lost their jobs anyway. And we know that that's part of our whole business system, that people are frequently losing their jobs. I would like to see us use losing insurance jobs taken as a model for how to deal with people losing any kind of jobs, because an industry shuts down or because a company moves their factory to a country where they can pay subsistence wages. How do we deal with that? And we are a rich country. We can afford to take care of workers who lose their jobs rather than pay them to do harmful things. And we can think about also about the whole prison industry, which is an industry. We should not be paying people to incarcerate other people and treat them cruelly. It would be much better to lay those people off and just pay them to stay home. At the same time, developing opportunities for people, whoever wants to train in jobs that are actually useful. There are lots of useful jobs that we're not paying anybody to do. We need personal care assistants to go out into the community and help take care of seniors and people with disabilities. We need to expand our public health workforce. We need a huge expansion of that. We should be having people out in communities going around door to door, talking to people about testing for COVID and about immunization. We need more teachers. We need more people in childcare. We need more people in providing recreational opportunities for young people. So two things: we should pay people to stay at home rather than pay them to do things that are harmful, and we should develop opportunities for people to work at jobs that are actually helping other people instead of harming them.
And I agree 100% with you, Anne, but all I'm going to say is that we can't even pay people a living wage.
Well, we could.
Well, we could, but we can't, you know.
We're not doing
it just gets stripped out of the bill, you know. So it's like, it's just very discouraging. But I'm glad I joined the call. I'm hearing wonderful ideas, but wow,
I hear what you're saying, Deborah. And I just, maybe I'll put this in the chat also. I just watched a film called Mandela in Chicago. And somewhere in that film, I can't even remember who said it. It's a marvelous film. But somebody, we know the huge fight that the decades-long fight to end apartheid in South Africa, and that struggle is not ended because with the end of formal apartheid, that still does not mean that Black people have the opportunities.
So Anne, we've got more than decades here in the United States. We've got centuries. Okay, we've got centuries.
I heard a quote in there that struck with me, that every failure is a victory. And what I think this person meant by that is that, and somebody else said recently, we win by losing. That when we're up against such huge and malignant powers, that we're not going to win immediately, and that we have to somehow find the hope to go on in spite of all the losses that we feel. And I have my times of discouragement too. And when that happens with me, what I do is look for somebody who's not discouraged, somebody who's still acting out of hope, and I follow them. So when the nursing home workers went on strike, I went out and I went out and joined their picket lines. I didn't have to do anything except turn up. I didn't have to feel anything. I didn't have to have any ideas about how things were going to go forward. I just could take my body there. So to me, that's what I do if I don't have hope myself, is to follow somebody who's acting out of hope.
Thank you. Sue Paston, you had your hand up for a while. Take yourself off mute.
This, what we just discussed, how much in reality will HR 1 change this to free both parties actually from, depending so much on big donors? Right now, we small donors manage to turn around the state of Georgia, So I'm wondering if HR 1 passes, will that help with Quigley and other people, even if they may have philosophical differences with Medicare for all, at least they begin with a public option or something. And number 2, it occurred to me that Medicaid is really like substandard. It's a wonderful system. It's better than nothing, but it's substandard cure for the poor. And so eventually under a Medicare for all system, I would hope that Medicaid would be folded into Medicare for all. And finally, I was supposed to be spokesman for Group 4, and a couple of people had a couple of other questions. Let me see if I can find them. Which we kind of discussed. What about jobs for people in the insurance companies? And again, they'd have to, pay them to stay at home rather than do harm. But people don't always want to stay at home, even, maybe at 75 or 74, yeah, but not at 50 or 20. So what about, other industries? It's always the transition. and using people who are displaced as a model for how we deal with displaced workers certainly would make care. I asked about, would Medicare for All cover alternative treatments that might be so new they haven't been yet approved? Acupuncture back in the day was not approved. A lot of things were not approved. Herbal medicine was not approved. Now today, of course, it is. What about, I mean, people, some of it's quackery, but some of it's very good. Some of it is Semmelweis washing his hands, if you get the reference.
Mhm.
So what about, I mean, don't we need a system that will recognize alternative treatments? And, okay, somebody else mentioned French doctors complaining that they don't make enough money. I don't think doctors need to be millionaires, but don't they need to be $100,000 or $200,000 or $300,000 heirs? Because that's a lot of education. That's a lot of studying. They have a lot of expertise. So.
Okay.
Thank
So
you. Sue.
HR1, I mean, this is outside of my expertise. So I've heard conflicting ideas about how much difference it's really going to make. I think that's a separate subject, but something we all, of course, it's really important to all of us. The public option will not change the healthcare system. It's not, first of all, it's not going to pass. And secondly, it wouldn't work if it did. We have to get the insurance companies out of healthcare. Medicaid, there would not be Medicaid any longer because everybody would have Medicare for all. The services that are currently covered under Medicaid that Medicare, for instance, doesn't cover, like long-term care, Medicare would cover. It's going to cover everything. That's what we're working for. So Medicaid would be obsolete. It wouldn't exist. And jobs, as we talked about, it's better to pay people to stay at home rather than pay them to do harm. But yes, everybody should be offered retraining. There are lots of, if we all put our imaginations to it, we would come up with lots of areas of work where we need workers, green energy, home care. We also think that many more people might become entrepreneurs because they wouldn't have to worry about health insurance. So many of us believe, and the National Nurses Association has actually done a study where they think that single-payer healthcare system would be a stimulus to the economy because people would not be stuck in jobs that they hate just to keep their health insurance. Alternative treatments, that kind of thing. Well, every payer system has to have a method of deciding what treatments will be covered and what will not. And that could involve alternative treatments and also standard treatments that we might come to find are not as good as we thought they were or that have become obsolete. So Medicare has such a system. Every insurance company has such a system. The difference between Medicare as it is now and private insurance companies is that Medicare has a public forum for deciding that. So people can submit evidence on whether a new treatment should be covered or should not be covered. So that's what we would want, an open public forum in which changes to coverage can be decided. And then doctors, of course, everybody complains about not making enough money. I mean, that's part of what we do, doctors and nurses and everybody. But, doctors, there's no country in which doctors are poor. And doctors in this country, if we continued to pay every doctor exactly the same thing that we paid now, and we changed to Medicare for all of those doctors would get a raise because they would not be devoting huge amounts of their time to dealing with insurance companies for which they do not get paid at all. So that would be
It'd be a boom.
They wouldn't have to pay people to sit in their office and decide whether somebody's insurance works or not.
Right.
Yeah. So people it would just be that would be a benefit. So yes, people are always going to complain that we work too hard for too little money.
Right. Okay, thanks.
You're welcome.
I think this will be our last question from Vicki Ward Martin. Use of Medicare for all term. When I first heard the term Medicare, I was confused thinking it was Medicare with the implications of the current Medicare for which I pay for. I'm just saying, for example, ACA, we know exactly what it is. In other words, Vicky, did you want to say anything else or?
Yeah, I was just saying it's an educational piece. I work with another organization. It totally turned me off when I heard Medicare for all. Do I have to pay for you too? This and that. And so I'm just saying, sometimes
So-
it was just confusing. You clarified a lot, but it really turned me off. I didn't even want to hear.
Okay, so we try to always say improved Medicare for all.
Okay.
So, and I don't think there's any way that the terms that we use can, in and of themselves explain what we're about. We have to say what we mean by it. That when we say improved Medicare, and we take Medicare because it's already a national system, the basics of the system are already set up. So expanding it to everybody and greatly expanding the things that it covers and eliminating all of the out-of-pocket costs, those are relatively simple compared to the system that we have now with where everything changes every year and where people have so many different kinds of insurance. But the important things are automatic coverage for every person who lives in this country, no out-of-pocket costs, 100% of all necessary care is covered, free choice of providers. We have to explain that those are the things we need, and we have to explain that we have to fight for them because we're not going to get them without fighting.
Cool. Thank you.
You're welcome.
Well, thank you, Dr. Scheetz. This has been
Welcome.
very educational
to all
and
of you.
inspirational.
Thank you to all of you.
And I
And
hope
I
all of
did put
our
my,
participants have been motivated by your story. This is
And-
Women's History Month. This is a woman who is making history and a good example for us to follow. So we will be sending out by email the links, if you don't have it in your chat, to the petition that Dr. Scheetz talked about and any other links that she provides for us. And I thank you all for attending.
Thank you so much
Back
for
next
having me.
month.